Kitab Al-Fatihah. Okay, right. Again, I'm sorry for the delay on my part. But anyway, I hope we can learn something from this session, inshallah. Okay, let's begin the session. Tafadhal.
Assalamualaikum. My name is Hadika. So I will be the first presenter for tonight's seminar, which is neonatal jaundice. Next. Okay, so this is the content. We go to the definition, bilirubin metabolism, approach to neonatal jaundice, and investigation and management. Next. So, okay, from the definition, we know that jaundice is meant by yellowish discoloration of the sclera, skin, and mucous membrane due to increase in the serum bilirubin. But from its protocol, it mentioned that it is when the serum bilirubin is clinically detected by more than 85 micromole per liter or more than 5 milligram per deciliter. Next. Okay, so before we know that neonatal jaundice is when the baby, usually less than 1 month, happen to have jaundice. So we need to identify the risk of the baby to have severe neonatal jaundice, which is listed down below, which are prematurity, low birth weight, jaundice in the first 24 hours of life.
Pause. 1 minute, 1 second, 1 second. Pause. 1 second. Sorry.
Okay, Doctor.
Okay, continue.
Okay, so we continue with risk factor for severe neonatal jaundice. We need to identify whether the baby is premature, low birth weight, jaundice at the first 24 hours of life, which is more of the pathological jaundice, mother with blood group O or rhesus negative, speedy, rapid rise of total serum bilirubin, sepsis, lactation failure in exclusive breastfeeding, high pre-discharge bilirubin levels, cephalohematoma or bruises, babies of diabetic mother, and family history of severe neonatal jaundice. It is important to identify this risk factor because high bilirubin level could lead to acute bilirubin encephalopathy such as tinnitus. Next. So I guess everyone is familiar with the bilirubin metabolism, which starting from the breakdown of BC, bind with albumin to transfer to the liver to be conjugated and excreted by the biliary system and excreted to the stool or in the kidney by urine. So any pathology coming from the red blood cell itself or the liver, whether it is unconjugated or any stasis, could lead to jaundice. Next. So we go to type of bilirubin. So there's a two type, unconjugated and conjugated. So unconjugated, just mentioned before, it binds to albumin and it is lipid soluble. However, the dangerous of the unconjugated bilirubin is it can cross blood-brain barrier, which can later lead to toxicity in the brain. For the conjugated, it is conjugated in the liver and very water soluble and excreted in the urine and stool. This conjugated bilirubin does not cause tinnitus, so it is not toxic. Next. So causes of jaundice, we can either classify it by unconjugated or conjugated. For unconjugated, we can list either hemolytic causes or non-hemolytic causes. I sure you guys already seen this classification previously on the seminar on jaundice. You can go through it later. Next. This is for the conjugated causes. It usually either due to the conjugation problem or obstruction or stasis. Next. Most of the time in the clinical setting, we can look the causes of jaundice based on the pathology, on the onset of the jaundice, whether it is less than 24 hours of life, or first day of life, or second day of life until 14 days, or more than 14 days or 2 weeks. Um, Most of the time, for the less than 24 hours, it is caused by hemolytic causes such as resist incompatibility, ABO incompatibility, or G6PD deficiency, or can be also by congenital infection. Um, for 24 hours to 2 weeks, it is most likely to be extremely common, and it can be physiological causes or just it can be also pathological. For the more than 14 days, it is can be also unconjugated and conjugated, but we need most of the time this need to be investigated, especially for conjugated jaundice. Next. So for physiological jaundice, as mentioned previously, it is a jaundice that appear between second day of life until 14 days of life. It usually appear during second or third day of life and will reduce and disappear by 7 day of life or maximum 14 days of life. It does not appear severe, usually only cause mild jaundice, and it is common to for babies who have physiological jaundice. So it is mild presentation. There's no need to for treatment unless there's a sign of worsening jaundice. So usually baby uh, during this time they will be only monitoring for the jaundice progression. And because why we call it physiological jaundice, because in newborn, basically they have high hemoglobin concentration, and also the RBC lifespan is quite shorter compared to normal RBC lifespan, and also
Why?
when
Why RBC lifespan is shorter?
because newborn has hemoglobin F, which is much
Yes, different type of hemoglobin. Hemoglobin F has higher oxygen affinity and it is
hemoglobin
a shorter lifespan. Okay,
F.
all right, fine, proceed.
And also because of the liver immaturity in the newborn, so this will cause jaundice in the newborn. Next, so for pathological, uh, must this usually always indicate pathology when the baby have jaundice in the first day of life within 24 hours or after 2 weeks of age. It can be for the first life, such as hemolytic disease mentioned above, or it can be prolonged jaundice, which the jaundice occurring more than 14 days in term and or more than 21 days in preterm. It can be unconjugated or conjugated, and this kind of prolonged jaundice always need to be investigated for the underlying causes. Next. So this is the features of physiological and pathological. Uh, Already mentioned about the onset is different, and also pathological if there is any rapid increase of the total bilirubin or persists more than 2 weeks, or any features of conjugated hyperbilirubin such as clay colored stool or dark colored urine uh, must be suspected for pathological jaundice and investigated. Next. Here is a bit to explain about breastfeeding and breast milk jaundice. It is also among causes of jaundice. What is the difference is for breastfeeding jaundice, it is happen because there is insufficient of breast milk uh, from baby. So the baby actually doesn't have adequate breast milk. So there will be low calorie and reduce the bowel movement and removal of the bilirubin from the body. So that's why you give in this breastfeeding jaundice, the treatment is to to increase the frequency of the breastfeeding, and also for lactation support, which uh, uh, to give education on how to properly lactate the baby. Okay, so breast milk jaundice, the difference is it is quite unknown because it is mentioned that breast milk jaundice have a substance in the mother's milk that inhibit the ability to for the infant to process the bilirubin. So most of the time the treatment will be phototherapy. However, it does not make that the mother cannot breastfeed the child. Uh, because the benefit of the breastfeeding is much more higher than these consequences, so it is encouraged for the mother to frequent their breastfeeding, and also if there's a reduce of fluid, then can be supplemented by formula milk. Next. So before I have mentioned that high uncoagulated bilirubin can cause cross the blood-brain barrier, which can cause kernicterus. So the kernicterus is very dangerous because it can lead to neurodevelopmental problems such as features such as dystonia. Attitude cerebral palsy is a dyskinetic cerebral palsy which causes abnormal movement, paralysis of outward gaze, where the baby cannot gaze upward, and sensory neural hearing loss. So in this characters, usually they feature from the imaging using MRI will show a yellow staining of the either basal ganglia, hippocampus, geniculate bodies, brainstem nuclei, and cerebellum. Depend on this.
Just to remind, kernicterus is actually a post-mortem diagnosis. So when the patient is alive, so you should say bilirubin encephalopathy or bilirubin induced neurological deficit, bilirubin induced neurological disease, or bilirubin encephalopathy. That would be the preferred rather than kernicterus.
Okay, so next. So now we go to the approach to neonatal jaundice. So from the history, we need importantly we ask the onset of the jaundice itself, because we need to identify whether this is more on the pathological or physiological jaundice, and history of previous infant with neonatal jaundice, neonatal death, or just SPD deficiency can be asked to identify the risk of severe neonatal jaundice. For consanguinity, because for certain diseases such as inborn error metabolism can causing jaundice, which are high among those who have consanguinity marriage. So also important to ask about the maternal and birth history, because this can identify, can we can assess the severity, risk of severity of the jaundice, and also to identify the underlying causes, such as we can ask either whether the baby is small size, or and then the blood type for the mother and the baby, if the mother is diabetic during pregnancy, maternal infections, cross infection, or traumatic delivery using forceps or vacuum, parental asphyxia, and then also to identify if the baby present with any abnormal symptoms such as apnea, difficulty in feeding, feed intolerance, and temperature instability. So from the history also we can identify whether it is conjugated or unconjugated based on the causes, such as for unconjugated we can ask for the feeding pattern, type and amount of milk intake, because this can be caused by breastfeeding jaundice, and also presence of vomiting and irritability for feeding intolerance, also for breastfeeding jaundice. And then family history mentioned above, drug history, because some drug can cause hemolysis, and the mother is taking some drug that can cause which transmit during the breastfeeding, and small progestation and birth trauma such as hematoma. So for unconjugated, we can ask the parents regarding the baby's stool and urine color to identify either it is conjugated bilirubin, and also some patients with biliary atresia usually have features of failure to thrive, and it is present in colon jaundice, so we can suspect that for babies coming jaundice for more than 2 weeks, and then also maternal or perinatal history, and family history of jaundice, liver disease, and metabolic disorder. So from physical examination, we need to look at the general condition. Also, important to look at the weight and sign of sepsis, and also hydration status. And then apart from that, we can also look for sign of acute bilirubin encephalopathy, which we will go through later. And also look for any plethora, cephalohematoma or subapneurotic hemorrhage because this can cause hemolysis of the blood and causing unconjugated hyperbilirubinemia. And then type of uterine infection, intrauterine infections such as petechiae, hepatosplenomegaly, and to see the severity of the jaundice. Based on the later, we'll use Kramer's rule. Next. This is a visual assessment of jaundice. We can use Kramer rules to estimate the the amount of bilirubin in the child. So usually it comes from cephalopowder from the head up until the extremities. So if usually marked jaundice, they will only appear at the around head, neck, and upper trunk. However, for severe, the baby can either up until the toes or the whole body will appear jaundice. However, for a child with a little dark skin, probably will be quite difficult to identify using Kramer's rule, and it is unreliable when on phototherapy. Next. This is the acute bilirubin encephalopathy. This score is used to quantify the severity and progression of the acute bilirubin encephalopathy based on the mental status, muscle tone, and also cry pattern. When we look at the score, we will add it and classify either to it is advanced acute bilirubin encephalopathy, moderate, or mild based on the scoring. 7 to 9 is advanced, 4 to 6 is moderate, mild 1 to 3. Uh, However, for preterm baby, it is better to use auditory brainstem response because in this group of babies, they doesn't manifest much the features of bilirubin encephalopathy. So it is better to do a screening for hearing of the newborn to identify the progress of the acute bilirubin encephalopathy. Next. Okay, so as mentioned, weight is important for the assessment of the baby because we need to identify whether there's the breastfeeding is adequate or not. So it is important because but through breastfeeding and frequent breastfeeding, it can eliminate the jaundice even better. And from the breastfeeding, we can ask the mother whether they have adequate breastfeeding by looking at the baby. Is the baby breastfeed like 8 to 12 feeds per day, and did the mother change the pampers, nappies in like 5 to 6 times, and after the feeding, the baby will latch spontaneously, release release the nipple spontaneously and look content after the feeding. So we need to also access this so that if for the management it can be uh, can educate the mother if the mother needs some help in the breastfeeding technique. Next. So for investigation, most of the time, if the baby come with during the physiological during second day of life to 14 days, they usually doesn't require any investigation, but need aggressive monitoring to identify if there's any rapid rise of bilirubin. However, for any babies with severe hyperbilirubinemia, early onset, less than 24 hours, rapid rise, more than 0.5 milligram per deciliter, need to be investigated for underlying cause of hemolysis. So we can send for G6PD testing. However, in Malaysia, we already do G6PD testing screening in newborn, mother and baby's blood group, direct test for hemolysis causes, full blood count and peripheral blood picture, reticulocyte count, and also septic workup if suspicious of infection.
Presenter,
Yeah,
presenter.
yeah.
My question. Okay, if you have a child who is probably, we say 5 years old, probably 5 years old boy, didn't do disability testing at birth because was born in private hospital, so they didn't do disability testing. So came in with jaundice, pallor, and then jaundice, tea-colored urine. History of eating fava bean. So what would be your most likely diagnosis?
GCPD deficiency.
Okay. Would you do disability testing at that particular time? Again, 5 years old, never screened for GCPD, had a history of eating fava bean, and then became pale and jaundice, dark colored urine. And you think it's most likely disability deficiency. So my question is, would you do disability testing at that particular time? Would you do or would you not do?
Not do.
Why not do?
Because the probably because the diagnosis is already towards the deficiency. I'm not sure.
No lah. So basically macam ni. What is the problem with GCPD? Apa pekerjaan GCPD tu?
Dia prevent oxidation.
So GCPD is an enzyme that protects the integrity of the hemoglobin. It protects the maintain hemoglobin against oxidative stress. Bila ada oxidative stress, dia boleh hemolyze, kan? Oxidative stress ataupun sulfur containing medication, kan? Okay, so isunya adalah dia bukan G6PD absence, dia G6PD deficient. Maknanya ada some of your hemoglobin has G6PD and some does not have. Some of your RBC has G6PD. Some of the RBC do not have G6PD. So, bila ada oxidative stress, bila ada stressor, bila makan fava bean, what happens? RBC yang tak ada G6PD tu will hemolyze. So, RBC mana yang tinggal? Yang tinggal will be those RBC yang ada G6PD. So, bila dah hemolyze, tinggal yang normal RBC dia. Kalau you buat GCPD testing, you will nampak dia normal. That is why we don't do. So, patients like this, we treat as GCPD deficiency, and then we need to do GCPD screening 6 weeks, 3 months after the onset. Okay. Boleh? Alright, fine, proceed.
Okay, so thank you for the input. And then for the investigation, to measure the bilirubin level, usually we use transcutaneous bilirubinometer, which is a non-invasive device that can detect the bilirubin level on the baby's skin. And however, for cases where the baby undergo phototherapy, this device is not reliable to measure the bilirubin level, so we will use total serum bilirubin in the baby. So other tests can be done if there is suspected of other causes of disease, such as liver function test for any liver pathology, thyroid function test if there is a presence of thyroid problem, and ultrasound of the biliary tree to identify if there is any cholestasis or biliary tract problem. Next. So this is the algorithm management for neonatal jaundice. Usually, when the baby is born, if the baby born in the hospital, usually they can detect earlier if there's any jaundice in the 24 hours of life. So once they detect there's a jaundice, they can go for treatment such as phototherapy or extended transfusion. However, if more than 24 life, if there's no features of jaundice, there's a features of jaundice, the baby will be observed and monitored for the jaundice to reduce and can be discharged once the jaundice is off. For the GSPD, the baby will be admitted at least like 5 days until the jaundice resolved and treated with phototherapy or exchange transfusion. Next. So indication for referral, just just mention basically if the baby is suspected for the pathological jaundice, like the onset is less than 24 hours, the jaundice appears severe below umbilicus or until extend to the soul, and then the family has history of significant hemolytic disease, or the baby appear unwell with jaundice or prolonged jaundice. These features will need indication for referral. And the baby with unconjugated hyperbilirubinemia can be investigated and referred if the cause is not sure. And conjugated hyperbilirubinemia always need urgent referral to the hospital for the management. Next. So the mainstay of the treatment for neonatal jaundice is phototherapy. So there's many types used such as LED, fiber optic, halogen bulb, and fluorescent tube. So for effective phototherapy, we use blue light, and the distance should not exceed 30 to 50 centimeters from the baby. Uh, uh, because using phototherapy, there's a care needed to be taken, which we need to monitor the vital signs such as temperature and hydration status. And the baby during the phototherapy session need to be adequately exposed. And while the eyes need to be covered, so to prevent retinal damage, uh, even though there's phototherapy, the baby need to be breastfed, and it can need to be breastfed. This phototherapy enhance the uptake of the bilirubin to be excreted. So we can look for when the baby on phototherapy, there's some complications that need to be monitored, such as dehydration because of the increased insensible water loss, or slow stool, irritability or lethargy, skin rash, overheating, retinal injury if not protected the eye, and also tanning or bronze baby syndrome. This happen when we use phototherapy on baby with conjugated hyperbilirubinemia, because the issue will be because the jaundice happen because of conjugation, not because of the high of unconjugated bilirubin. So the baby will appear tan or brown, bronze. Uh, so for extended transfusion, it can be used if the phototherapy does not work, and or the baby appear have severe hyperbilirubinemia. This is to prevent the connectors and also to reduce the progression of acute bilirubin encephalopathy. So we can usually exchange transfusion will use fresh whole blood, and the exchange will be 2 times the infant total blood, or use the reconstituted fat red blood cell and fresh frozen plasma in ratio 2:1. So this also need to be further monitored for any complications such as thrombocytopenia, necrotizing enteropholitis, arrhythmia, any electrolyte inability, apnea, or renal failure. Next. So for the management, other than mainstay of the phototherapy and exchange infusion is screening. We can screen for to prevent any blood incompatibility, and also screen for GSPD deficiency. Also for thyroid screening during, I think thyroid screening is done in Malaysia during the delivery, and also screening for any inborn error metabolism. So for prevention, um, we can give NTD, which is Rogam, for those mother with disease negative, and encourage mother to breastfeed. Also, education is important because um, uh, certain some mother are not very well educated on the causes of jaundice and the treatment available. Uh, some uh, some may believe that expose the baby to sunlight can relieve the bilirubin. So this is need to be need to be educated better, because exposed to sunlight only causing dehydration and further worsen the jaundice. So I think that's all from me. Any question?
I have a few questions. For the phototherapy just now, what skin rashes can appear? And next is a retinal injury. For phototherapy, we usually close the eye, right? So is the retinal injury still occur? And next is for exchange transfusion, when intensive therapy is failed. So when we can say that the intensive phototherapy has failed, when we can say that we already do intensive phototherapy. That's all.
Presenter, cepat.
Yang kedua tadi apa?
Tidur
Soalan tadi?
presenter.
Bukan, sebab banyak sangat.
Sorry, the first one is about skin rashes, second about retinal injury, third about intensive phototherapy.
So for rash, it may appear peticate or purpuric rash. I think. I'm not sure about that.
Peticate rash. Peticate rash is because of thrombocytopenia. Biasa peticate rash is thrombocytopenia or vasculitis. Dia akan jadi peticate or purpuric. Biasanya because of that. So this lesion usually more of like erythematous type of lesion. Erythematous type of lesion. Kenapa? Sebab dia it's just that the generally okay. Previously lah, sekarang ni some hospital still use, dia guna fluorescent light. So kita nak bagi blue light at the 350 to 450 nanometer dia punya wavelength dia. So if there's many type of lights, halogen light which is memang produce heat banyak, intense light. Tapi fluorescent light pun still produce heat. Sekarang ni kita sama ada mainly kita guna LED ataupun guna fiber optic. Both of which doesn't produce heat. So bila you bagi heat pada kulit, what's going to happen? Sunburn, heat rash, this sort of thing lah. So dia akan jadi nampak erythematous type of rash. So sama juga dengan isu retinal punya injury, basically because of direct exposure to sunlight. Lepas tu kita kena cover the eyes. Zaman dulu-dulu, when I was born in 1981, I was born borderline premature, IUGR. I have DCPD deficiency as well. I had severe jaundice when I was young, almost reaching not reaching lah, already at exchange transfusion level. I personally escaped ET just because there's another baby who had more severe jaundice than me. Dulu orang used to put babies under the sun. Maknanya pagi-pagi tu kan, waktu fajar tu, fajar sore tu dia panggil, waktu very clear white light tu, parents used to sunbathe the baby. So they cover mata dia, cover mata and then dia itu. So what's the problem with that? The problem is sun ray is not just blue light. Sun ray is so many lights. Dia ada infrared, ada UV, ada so many other lights kan. And all these lights are harmful. Infrared can cause skin cancer, cause sunburn and so on and so forth. So we don't do that anymore. Dan kita tak guna dah fluorescent light sebab it produces heat. If you look at the complication, tengok sebelah. Okay, dehydration. Kenapa dehydration? Sebab heat, is producing heat. Kan? Sekarang ni with LED and fiber optic, our problem now is actually instead of hyperthermia, our problem is hypothermia. Sebab apa? Sebab LED doesn't produce heat. Baby pula kita kena buka baju apa semua. Dia expose dengan our ward tu air condition. So it's very cold. Macam nak maintain baby temperature. So that's one issue. And then second, sometimes bila dia blue light, mother tak comfortable. So sometimes feeding pun boleh reduce. So sebab tu kita kena cover eyes dia sebab reduce risk for retinal injury. Overheating ni is problem with fluorescent lah. Sekarang orang tak guna dah fluorescent. I think very few hospitals still use fluorescent light. Itu pun kalau emergency bila tak ada yang lain dah. Okay, back to exchange transfusion. Exchange transfusion, bila kita kata intensive, what is intensive phototherapy? Intensive phototherapy is basically when you give phototherapy more than what you usually give. So usually kita letak satu lampu. Bila kita letak dua lampu, that's intensive lah. Sama kita letak 3, 4 kita letak. So more areas exposed. Ada one study as well, dia guna satu light tapi dia letak reflector curtain. So dia reflect the light. So basically to increase the area of exposure to phototherapy. So that is intensive phototherapy. When kita kata dia phototherapy has failed, bila bilirubin tak turun. Bila kita bagi intensive phototherapy, bukan setakat tak turun, dia makin naik. So maknanya the rate of hemolysis is faster than the rate of treatment with phototherapy ni. So that is intensive phototherapy, kita kata fail. Okay, my question. What does phototherapy do? Kenapa kita buat phototherapy? Macam mana phototherapy ni reduce bilirubin level?
Photoisomerization, doktor.
Oh yes, photoisomerization. Because we know unconjugated bilirubin is lipophilic and hydrophobic. Being that it crosses the blood-brain barrier, kan? So apa kita buat? Kita photoisomerize, change the molecular affinity so that it becomes more hydrophilic. Bila dia more hydrophilic, it can be excreted through the kidney, through the urine, and through the enterohepatic circulation. So that is what we do with phototherapy. Okay, all right. Izzah, did we answer your question? Did we? Me and the presenter lah.
Yes, doktor.
Yeah.
Yes, Haziko, thank you.
Okay, wait. Before we end and before we change to the next presenter, why 14 days? Why 14 days in term and why 21 days in premature baby?
It's because of blood-brain barrier is matured at 14 days.
Okay, so how do we know it's 14 days?
How do we know tu? I tak tahu.
So this 14 and 21 days is actually just a number that is plucked from the sky. Plop, pop. There's no actual study that actually proves to us by 14 days in term babies the blood-brain barrier is already mature. There's no clear study. It's just from observation. We observe from 14 days onward, high bilirubin doesn't actually affect the babies much. So we assume by 14 days the blood-brain barrier is mature enough so that unconjugated bilirubin does not cross too much into the brain. So that's why it's just an assumed number just based on observation. It's very difficult to get ethical pass to do this sort of studies in premature babies or in any baby. So that's the reason why. So it's just a plug number 14 and 21 days. Okay, why we exchange transfusion in this slide? Twice, 2 times blood volume. Why not 3 times? Why not 4 times? Why not just 1 time? You're already replacing everything. Kan? Even 1 time, you are replacing everything. All the blood, baby tu ada, kita replace. Apa tak cukup? 1.
I think to cover for the hemolysis. Not sure.
So basically again, this is based on study lah. Okay, when you do exchange transfusion, it's not that you drain semua blood dia kan. You drain semua blood tinggal kosong lepas tu you replace. Kalau you buat macam tu boleh lah, basically you replace everything. But in human being, it's not possible for you to drain all the blood. Faham tak? Kalau you drain semua blood dia, lepas tu you replace one, maknanya betul-betul dapat new blood lah kan. Tapi with exchange transfusion, in children, in human, you cannot exchange like that. Sebab apa? Sebab even 5% blood loss is already A lot. 5% is already shock. 5% blood loss is already in shock. Kan? Apatah lagi 100%. So that is why you can exchange it slowly. You exchange it slowly. Maximum is 5 ml per kilo. That's maximum. Okay, so bila kita exchange, contohnya one single exchange transfusion, one blood volume, or double or whatever, kita exchange macam mana? Kita exchange, kita ambil keluar sikit 3 to 5 ml of blood slowly over 1 to 2 minutes. Lepas tu kita wait 1 to 2 minutes, and then kita slowly replace for 1 to 2 minutes, and then kita break 1 to 2 minutes, and then kita drain balik 1 to 2 minutes, kita wait, and then kita push 1 to 2 minutes. So that is how we do it. So macam mana kita tahu yang kita ambil itu is actually baby punya blood sahaja, bukannya blood yang kita masukkan. We don't know, kan? So that's why even if you do one time blood transfusion, one single total volume transfusion, you are not actually removing 100% baby punya blood. You may actually remove the blood that you have transfused. Okay, so studies have shown. Okay, so in that sense, bila you buat double volume blood transfusion, more of baby's blood is actually being removed. Sebab it's double volume, kan? But it's not you actually remove twice. It's just that you by 2 times you are removing more of baby's blood and replace with the low bilirubin level donated blood. So kenapa tak buat 3 times? Bukankah 3 times lebih efektif? Kenapa tak buat 4 times?
Cost.
Huh?
Not cost effective.
Yes, because it's not cost effective. Because blood transfusion has so many complications. Blood transfusion has risk of infection. You know, HIV nowadays, they don't, you may detect viruses, they mutate. So risk of hepatitis, HIV, risk of infection, risk of what? You are not just removing RBC, you are removing FFP as well. You are removing plasma, you are removing coagulation profile, you are removing complement, you are removing all those other factors that are not available in the donated blood. Because donated blood are processed. They don't have the immunoglobulin and so on and so forth. Don't have antibody in it. So you are removing good factors. You are removing calcium with it as well. Among the problem is calcium, hypocalcemia, hypokalemia, hypermagnesemia. So you're removing all good products as well. So the more blood you exchange, the more complication is there. Studies have shown double volume blood transfusion is the most cost effective volume for you to be exchanged. Yes, single volume, you reduce the bilirubin. Double volume, you reduce the bilirubin more efficiently. 3 time volume exchange, yes, it still reduces, but it already plateau. Bila dia dah plateau, maknanya dia kurangkan, tapi it's not that significant as compared to double volume blood transfusion. So that's the only reason. Okay, all right, fine. Let's go to the next presentation. How many
Doctor,
presentation?
Doctor, Azika, I would like to ask question. My question is about the screening of inborn error metabolism. Okay, I read. Inborn error metabolism is one of the causes of neonatal liver failure. Okay, so such inborn error metabolism such as galactosemia, tyrosinemia, neonatal homochromatosis, and Wilson disease is one of the examples. Okay, my question is, how do we screen this inborn error metabolism in newborn? I mean, is it a routine investigation?
No, we don't.
Oh, okay.
Because it's rare, because it's expensive. Even if you do, results come back after 2 to 3 months. So you don't do.
So doctor, if the patient have so is it patient will come with persistent jaundice?
No, you need to read about IEM. So jaundice is not the main presentation for IEM. Inborn error
so
of metabolism, the chief complaint is not jaundice. The chief complaint will be other than jaundice. Hypoglycemia, hyperammonemia, urea defect, uremia, acidosis, high lactate. So those would be, or seizures, those would be the main presentation for IEM. If you have jaundice, don't think of IEM as the first thing. IEM will be much lower down.
okay, doctor.
Okay.
Thank you. Yeah.
All right. Fine. Next. How many presentation kita ada ni?
4 total.
Aduh. Okay. Fine.
Okay, Bismillahirrahmanirrahim. Assalamualaikum. So I'm Farah. I'll proceed with the next topic, which is about neonatal anemia, which is the most common hematologic abnormality in the newborn. Okay, so for under my topic, first we will talk about the definition, moving on to the normal physiology, and then the pathophysiology, and the last one is diagnostic approach and a bit about the management. Okay, so let's take a look at the definition. Okay, so right here I have put 3 definitions. So let's look at the first one. So the first definition, they define anemia as a hemoglobin level below the normal range. And according to this textbook, for neonate, it is hemoglobin of less than 140 gram per liter. Okay, so for the second definition, they define anemia as a pathological reduction in the hematocrit, hemoglobin, as well as the erythrocyte count. And the last definition, they define neonatal anemia as a hemoglobin or hematocrit concentration of more than 2 standard deviation below the mean for the postnatal age of the patient. So for example, if we have a neonate that we suspect anemia, we look at the hemoglobin level, as well as we need to know the age of the patient. Okay, so for example here, this is the normal reference range for the term newborn. So on the left side, we have the age of the patient, and on the right side, we have the parameters. Okay, so for example, after birth, for example, the baby is 1 to 3 days of life. You can see right here, the hemoglobin level is 18.5 gram per deciliter. However, as the patient grows older, for example, after 1 week, 2 weeks, 4 weeks, and so on, you can see the hemoglobin level has a decreasing in trend. So this is normal. Okay, so that is why, apart from looking at the hemoglobin level, you must know the age of the patient. Okay, so this one is another reference range I took from the protocol. You guys can look later. All right. So moving on to the normal physiology. So first I would like to talk about the erythropoiesis, or the process of red blood cell production inside the fetus and the newborn. Okay, so the important thing that you guys need to know here is that fetal erythropoiesis, they are independent of the mother, meaning that everything occurred inside the baby. Okay, so it occurred at 3 sites, which are the yolk sac, the liver, as well as the bone marrow. Okay, so look at the picture on the right side. You can see here at the early gestational age, the first site for RBC production is at the yolk sac. Okay, and then the liver will take the role. If you can see here, the liver is the major site for RBC production during the fetal development. Okay, and then at around 18 weeks of gestation, if you can see right here, the bone marrow will take the place of erythropoiesis, and after birth, the bone marrow will be the major site for RBC production. Okay, so now let's take a look a bit about the erythrocyte that is produced. So basically, there are a few differences between the neonatal erythrocyte and our erythrocyte, or the adult erythrocyte. So like the previous presenter has mentioned, they have a different lifespan. So our erythrocyte is around 90 to 120 days. However, they have a shorter lifespan. So in the term babies, it is around 60 to 70 days, and it is shorter in the preterm infant, around 35 to 50 days. Okay, and they also have different RBC indices. Normally, we can see larger MCV and lower MCC. Okay, let's look at the previous picture. So before birth, you can see the major RBC that is produced are macrocyte. That is why after the birth, we can see some larger MCV in the baby. Okay, and also the RBC are more susceptible to oxidant-induced injury, mainly because there is deficient in the phosphofructokinase activity. And also on blood smear, we can normally see high frequency of this morphology. So we know that our normal RBC is this in shape, right? However, in the term baby, the disc-shaped RBC are only 43%, And they also have normal spirocyte and poikilocyte up to 14%, and this amount is higher in the preterm babies. So that is why later when you want to investigate the patient, when you want to interpret the lab result, you need to interpret with caution because normally they will have different indices and they will have a normal dysmorphology. Okay. So next, I would like to talk about a special condition that occur in this baby. It's called the physiological anemia. Okay, so physiological anemia is a type of anemia that occur in the healthy term infant. It is essentially a benign anemia. Usually they are asymptomatic and no treatment is required for this anemia. Okay, so what happens during physiological anemia is that after the birth of the baby, we know that the baby will take their first breath, right? So when they take their first breath, more oxygen will be available to enter inside the baby. So because of that, more oxygen will be available to bind to this hemoglobin. So there will be an increase in the hemoglobin oxygen saturation. Okay, so before birth, this HB oxygen saturation is only around 50%. However, after the first breath, this HB saturation can increase up to 95%. Okay, so another important event here, after the first week, within the first week after birth, there will be a switching of fetal hemoglobin to the adult hemoglobin, or the HbF to HbA. So look at this, the picture below. After birth, the gamma globin will decrease and the beta globin will increase, hence producing the HbA. So like Dr. had mentioned before, the important thing here is that HbF, they have a higher affinity for oxygen, meaning that it is harder for them to release the oxygen to be given to the tissue. However, for HbA, they have a lower affinity for oxygen, meaning that it is easier for it to release the oxygen to be given to the tissue. Okay, so because of these two conditions, what happens is that when there is an increase in the hemoglobin oxygen saturation, there will be an increase in the blood oxygen content. Okay, and because of this HB switching, like I said before, HbA, they have a lower affinity for oxygen, hence more oxygen will be delivered to the tissue. Okay, so because of these two conditions, they will downregulate the production of erythropoietin or EPO. And we know that EPO is very important for erythropoiesis. So because of this downregulation, there will be a decrease in the HB concentration. Okay, and this reduction of hemoglobin will continue until the tissue oxygen needs is more compared to the oxygen that is available to be delivered to this tissue. Okay, so usually this will happen around 6 to 12 weeks of age, where the hemoglobin level can be as low as 9.5 to 11 gram per deciliter. Okay, so after around 12 weeks, the hypoxic state in the baby will be detected by the renal or hepatic oxygen sensor, and this will trigger back the increase of production in EPO and will resume erythropoiesis. Okay, so later the HB will increase slowly to reach the adult value by 2 years old. So that is why before, when I show you the table, initially after birth, the hemoglobin of the baby is high. After birth, 18.5. However, as the baby grow older, you can see there is a normal decreasing level of hemoglobin. So that state we call them as physiological anemia. Okay. So we look at the normal one. Now let's look at the pathophysiology. Okay. So basically there are a lot of potential causes for neonatal anemia, and to make it easy, we can divide them into 3 big groups. So first we have the hemorrhagic anemia, or due to blood loss, and then we have the hemolytic anemia due to increase in RBC destruction, and also hypoplastic anemia, which is due to the decrease in the production of RBC. And as listed here, there are a lot of causes, but for today, I will only talk briefly about some of them. Okay. So let's look at the first group, which is about hemorrhagic anemia. Okay, so please look at the yellow box below. This is important. In the neonate, the absolute blood volume is already low. So in the preterm, it is only 90 to 105 ml per kg, and in the term baby, 78 to 86 ml per kg. So when there is blood loss, as little as 15 to 20 ml of blood loss can result in anemia in the patient. Okay. So for the causes under hemorrhagic anemia, we can divide them into the period that they occurred, for example, antepartum, intrapartum, or postnatal. Okay, so let's look at the first one.
Presenter. What do you mean by absolute blood volume is low?
Volume in the baby.
What do you mean by absolute blood volume is low?
The total blood volume in the baby.
So the idea here is that in terms of mils per kilo, they have actually more than adults.
Okay.
If you see the younger the baby, the more premature the baby, the blood volume in terms of mils per kilo is higher. If you compare with adults as well, mils per kilo, babies have higher blood volume, mils per kilo. But the absolute blood volume is less. Because if, for example, a 1 kilo baby and a 3 kilo baby, who has higher absolute blood volume? Obviously, the 1 kilo baby. Because even if they have like 80 mils per kilo, obviously term baby have 80 mils per kilo. 80 times 30 has 240 mils blood only. 3 kilo baby only have 240 mils of blood. Preterm baby, they may have 90 mils per kilo total blood volume, their total blood volume. But absolute blood volume is just 90 as compared to 240. So in terms of mil per kilo, the younger the baby, the smaller the baby, they have more, higher in terms of mils per kilo. But the absolute number is less because of their size and so on and so forth. That is why you need to understand this, because, for example, if you take blood, do the amount of blood you take change with baby's size and baby's gestation? No. Maknanya, a 500 gram baby and a 6 kilo baby, the number of blood you need for FBC, full blood count, is still the same. You need around 0.5 mils of blood. Kan? Saya kira berat budak tu 500 gram ke, berat baby tu is 6 kilo ke, 11 years old ke, the amount of blood you need to take is still 0.5. If you need, for example, you need you nak hantar coagulation, PTA, PTT, INR, kan? The usual bottle needs 1.8 mils of blood. So can you imagine if the baby is just 500 gram with only 40 mils of blood? Baby to the whole blood volume is 40 mils. And you are taking almost 2 mils of blood. Kalau you nak ambil FDC, you nak ambil coagulation, you nak ambil PT, if you nak ambil RP, LFT, you need around 1 mil of blood. Kan? So you nak ambil apa? 4 mils. So 4 mils out of 40 mils. That's already 10%, isn't it? That is a lot. Okay, so that's the thing that you need to remember lah. Okay, fine, proceed.
Alright, thank you, Doctor. So I proceed. Okay. So the first possible cause of neonatal anemia that can occur in the antepartum period is the fetal-maternal hemorrhage, or the FMH. So FMH is the entry of fetal blood into the maternal circulation, can occur before or can occur during the delivery process. So they say that the amount of fetal blood that is considered as significant to be present inside the maternal circulation is 30 ml or more. And this condition is common because 75% of pregnancies have some small volume of fetal blood inside the circulation, but it is not significant, only 0.01 to 0.1 ml. But 1 in 400 has around 30 mils or more, and 1 in 2,000 has around 100 mils or more. And the associated factors with this condition, for example, they have history of direct trauma to the abdomen, involvement in MVA, motor vehicle accident, antepartum hemorrhage like abruption of placenta, or maybe the mother undergo procedures during pregnancy, for example, amniocentesis. So important for us to know because we need to ask this in the history later. Okay. However, we must note that up to 82% is due to unknown cause. And from what I've read, they say that FMH, they can occur spontaneously. Okay, so how to diagnose FMH? We do the Kleihauer-Betker test or KB test. So what they do is that they will take the maternal blood and they will do acid elution of hemoglobin from the RBC. So for easy understanding, what they will do is that they will try to remove the hemoglobin from the red blood cell and then they will stain the red blood cell. Okay, so we must know, you must remember, fetal RBC, they have HbF. Adult, they have HbA, and it is more difficult for us to remove HbF compared to HbA in the RBC. So that's why when we stain the cell, the mother's RBC will appear clear color, or we call this as ghost cell, because there is no HbA inside the RBC. However, for the fetal, since the HbF is difficult to remove, so when we stain, the RBC will appear pink. Okay. So another possible cause is the twin transfusion. So this is a complication that can occur in the monochorionic twin pregnancy, or basically a twin pregnancy where the pregnancy has only one placenta. Okay, so because of this only one placenta, it permits the transfer of blood from one twin to another. Okay, so the twin that is giving the blood, we call them as the donor twin, and the one that is receiving the blood, we call them as the recipient twin. So for today, in our context of neonatal anemia, we are talking about the donor twin. Okay, so this case can occur acutely where the twin will be similar in size, but there will be a HB differences of more than 5 grams per deciliter. But if it is a chronic case, the donor twin here usually will become progressively anemic and growth retarded or become more smaller, and the recipient twin here will become polycythemic and will become bigger or macrosomic. Okay. So this is just other features you guys can read later. Okay. So another possible cause is the antepartum hemorrhage. For example, like abruption placenta or placenta previa. I'm sure you guys know. Okay. And then in the intrapartum period, what may occur? For example, in precipitous delivery, like rapid and spontaneous delivery, which may cause umbilical cord tearing, causing the hemorrhage. Okay. Or another example, in difficult vaginal delivery, for example, in delivery of a macrosomic baby, which may result in occult visceral or intracranial hemorrhage, or maybe accidental incision of the placenta during C-section, okay, causing hemorrhage. Right. So in the neonatal period, another possible cause is internal hemorrhage, which may be due to birth trauma. So for example, here we have the carpal hematoma, we have subgaleal hemorrhage, we have intracranial hemorrhage, and a bit about subgaleal hemorrhage. It is a rare condition, but it is potentially lethal. Okay, so basically it is a hemorrhage in the subepineuritic space, this space right here. And this big space, a potential space, it is a very big space where it extends from the orbital ridge to the base of the skull. So this big space can hold as much as 260 ml of blood. That is why it is potentially lethal for the baby. And usually this condition is associated with instrumental delivery. Okay, so we need to ask that in the history, right? Okay, so now we move on to hemolytic anemia. So it can be further divided into immune causes, non-immune, as well as due to congenital erythrocyte defect. So the first one, example, under immune hemolysis, we have the isoimmune hemolytic anemia, which comprise of ABO and rhesus incompatibility, which is the most common cause under hemolytic anemia. Okay, another example is IHA. Non-immune, we have infection and sepsis. And also under congenital erythrocyte defect, we have enzyme deficiency, for example, GCPD. And then we have hemoglobinopathy here, for example, thalassemia. So when we are talking about thalassemia in the neonate, we are actually referring to the alpha thalassemia, because we know that beta thalassemia usually they will present around 3 to 6 months of age. Okay. And then another example are membrane defects, for example, hereditary spherocytosis and electrocytosis. Okay. And just a bit about rhesus incompatibility, just for recap. So what happens during rhesus incompatibility is that we have a rhesus negative man get married with a rhesus positive man, get married with a rhesus negative woman, and then they have a child with rhesus positive. For example, during delivery, the baby's blood enters the maternal circulation, and then the mother will produce anti-rhesus antibody. It will not affect that pregnancy, but it will affect future pregnancy. So that is why it is important for us to ask the rhesus status of the mother, because if we know that the mother is rhesus negative, then we can give prophylaxis, we can give program. Okay. So the next group is under the hypoplastic anemia. So for example of congenital cause, Diamond Blackfan syndrome, congenital leukemia. For acquired cause, may be due to infection, a plastic crisis or a plastic anemia. And the last one, it may be due to anemia of prematurity. Okay, just a bit about anemia of prematurity. If you guys can still remember, I talked initially about physiological anemia. It is a form of anemia that occurs in the term infant, but the preterm infant also have a normal reduction in hemoglobin. However, this normal reduction of hemoglobin that occur in the preterm babies is more severe, more rapid, more exaggerated compared to that occurred in the term babies. So this condition, we call them as anemia of prematurity. Okay, so the mechanism that causes this, similar like the term babies, because of the transition of HbF to HbA, because they have a shorter RBC lifespan, and also because of hemodilution due to rapidly increasing body mass, because the preterm babies, they grow much faster. Okay, and also the most important cause is iatrogenic causes or frequent blood taking or phlebotomy. Okay, so like I said before, if physiological anemia, usually it is benign, asymptomatic, no treatment required. But in anemia of prematurity, since this condition is more severe, the baby might have symptom and sign. For example, they might have tachycardia, rapid tiring with feeding, poor weight gain, increased requirement of oxygen, apnea or bradycardia, and also elevated serum lactate. So they might need treatment for this condition. Okay, and the reduction of hemoglobin, it can go as low as 7 to 8 gram per deciliter. Okay, and usually the smaller the baby is, or the more premature the baby is, the lower the hemoglobin level that we can see. Okay. So we have done with the causes. Now, how to approach a case of neonatal anemia? Okay. So there are 4 important things that we need to consider. First, what is the age of presentation of anemia? What is the associated clinical features? What is the hemodynamic status of the patient? And is there any compensatory reticulocytosis? Okay. So for example here, under hemorrhagic anemia, usually the baby will present the symptoms at birth. They will come with pallor, but no jaundice. They will have distress, for example, like tachypnea, and they can have vascular instability that can go up to shock, depending on the amount of blood that is lost. For example, if 10% lost, there will be a reduction in perfusion. If 20%, they can have hypovolemic shock. Okay. So for investigation, what we can find under hemorrhagic anemia, for example, for acute blood loss, we can find normochromic normocytic anemia. But if it is a chronic case, for example, chronic FMH or chronic twin transfusion, we can see hypochromic microcytic anemia. Okay, and then there will be reticulocytosis, because even though they are losing blood, but they are still able to produce more blood. Okay. And then another example is under the hemolytic anemia. So the main feature that you want to look at is jaundice. Okay, and they can also come with pallor, usually after 48 hours of age. They can come with tachypnea and hepatosplenomegaly. Okay, so investigation reticulocytosis, and because of the hemolysis, there will be an increase in the unconjugated bilirubin level. Okay, and then for hypoplastic anemia, from what I read, usually a case of hypoplastic anemia, they will come gradually, usually with chronic anemia, and they can present several weeks after birth. Okay, so they can come with pallor, no jaundice, and on investigation, since it is hypoplastic, so there is reticulocytopenia. Okay, all right. So for history, what we want to ask for HOPI, of course, the age of the patient, when is the onset of symptom, the anemic symptom, for example, pallor, irritability, poor intake, poor weight gain, symptoms of hemolysis, like the previous presenter mentioned, for example, changes in urine color. In chronic hemolysis, they can come with dark urine, jaundice, and any associated symptoms. Okay, so for the birth history, very important. So antenatally, we can ask, is it a single or twin pregnancy? How is the fetal growth during the pregnancy? And history of antepartum hemorrhage, for example, PV bleeding, and of course, mother's blood type and rhesus status. Okay, so intrapartum, what is the mode of the delivery? Any use of instrument, for example, forceps or vacuum? What is the gestational weeks of the patient when they are delivered? Is the patient premature or maybe term infant? What is the birth weight? Because we know low birth weight babies, they are more susceptible. And then bleeding or placenta abnormalities, and any history of birth trauma that the mother might know of. Okay. So postpartum, any bleeding tendencies or head swelling. For example, in cases of intracranial hemorrhage. Okay. So for the growth and development, does the baby have poor weight gain? And family history, very important, because we know some of the causes may be hereditary. So we must ask any family history of anemia, frequent blood transfusion, history of splenectomy, known case of thalassemia, for hemolytic anemia, and history of jaundice. And we know that a patient with hemolytic causes, they are prone to get gallstone. So any history of cholelithiasis or gallbladder surgery, and also splenomegaly. Okay. So for physical examination, what we want to look at first, generally, is the patient active or not? Is the patient in distress or lethargic looking since they are anemic? Any abnormalities like in the picture here, any scalp swelling or head molding? What is the color of the baby? Is the baby pale or jaundice or cyanose? The skin, any petechia or purpura, because it might indicate bleeding diastasis. Dysmorphic features in diamond blood fan anemia, for example, they can come with hypothyroidism or microcephaly. Okay, anthropometric measurement, very important because they might have poor weight gain. And another thing, hemodynamic status and vital sign, because the baby might in shock in case of blood loss. Okay, and then specifically for anemia, any tachycardia, cardiac failure, for example, they may have gallop rhythm and also distress. Signs of hemolysis, for example, jaundice and hepatosplenomegaly. Okay. So, how to investigate a case of neonatal anemia? So first, very important, you must do full blood count. We check the hemoglobin level to confirm they are anemic or not. Check the reticulocyte count to check whether there is any compensatory reticulocytosis, and of course RBC indices, because I said before, if it is a chronic case of blood loss, for example, they can come with hypochromic microcytic. If it is acute, they can come with normochromic normocytic anemia. Okay. And on blood smear, we can see, for example, spirocytes in cases of ABO, isoimmune hemolysis, pignocyte in G6PD. However, like I said before, when we want to interpret the blood result of the neonate, we must interpret with caution, because normally they will have some form of this morphology. Okay. And then we can do DAT, or formerly known as direct Coombs test, which can be positive in immune causes of hemolysis. We can do blood typing for isoimmune hemolysis, KB test, like I said before, to diagnose FMH, bilirubin level if you suspect the patient is due to hemolytic anemia, coagulation profile, if we suspect it is due to consumption coagulopathy, ultrasound, for example, if we suspect any internal bleeding, for example, ultrasound of the head, for intracranial bleeding, or abdomen, for example, due to visceral hemorrhage, okay? And then if we suspect the patient have hypoplastic anemia, we can do bone marrow aspiration, depending on the cause, okay? So this is just the summary. So So basically the patient is anemic by looking at the hemoglobin level, and then we look at the reticulocyte count. So we know that for a case of hypoplastic anemia, there is no reticulocytosis. Okay. However, if the retics is normal or high, we proceed with the Coombs test. So we know Coombs test will be positive in immune causes of hemolytic anemia. Okay. And if it is negative, we will look at the RBC indices. If it is hypochromic microcytic, usually it is due to chronic blood loss or alpha thalassemia. If it is normal or high, we proceed by looking at the blood smear. If it is abnormal, it is due to the these causes listed here. If it is normal, it might be due to acute cases of blood loss, for example, or infection. Okay, this is just the algorithm. All right. So how to manage a case of neonatal?
Back. Okay, Coombs test negative, MCT is low. Alpha thalassemia, what is beta thalassemia?
Beta thalassemia, usually they present around 3 to 6 months of age. So under neonate, hypoalpha.
Okay, fine. Alright. Alright, proceed.
Alright. So, okay. So proceed with the management, just a bit about the management. So the first management that we can give is simple replacement transfusion or blood transfusion. Okay, and usually the blood product that we will give to the patient should be leukocyte depleted, irradiated for infant weighing less than 1,200 gram, and we limit the we limit the we pick from selected donors to limit donor exposure. Okay. And then listed here are just the indication for blood transfusion. I think you guys can read later. Okay. And then another thing that we can give in patients similar like the previous presenter said, exchange transfusion. So for the indication, in cases of chronic hemolytic anemia or hemorrhage that have tissue hypoxia, in cases of consumption coagulopathy, or in cases of severe isoimmune hemolytic anemia. So we can do exchange transfusion. Okay. We can also provide nutritional replacement, for example, iron, folate, and vitamin E. And also we can give recombinant EPO. So this will help with increasing the production of RBC, and also it is one of the method that we can use to reduce erythrocyte transfusion, because we want to reduce complication of blood transfusion to the babies. Okay. And the last one, the important one, we need to treat the underlying primary disorder. So for example, if the causes, for example, in hemolytic anemia, it might be due to infection. So of course, we need to treat the infection to treat the patient. All right. I think that is all. These are my references. Any question?
Any question? Kita semua nak tidur belaka dah. Okay lah, I think anemia is quite clear. It's quite straightforward. It's just that you need to remember lah, it's quite common. Sometimes if a baby is born with, for example, hydrops fetalis, you need to remember anemia is fetal anemia is actually one cause of hydrops fetalis, because hydrops fetalis is basically heart failure. So anemia leads to heart failure and so on and so forth. And then especially in babies that are admitted to NICU, and being admitted in NICU is actually a cause for anemia, iatrogenic. Again, as I said before, because of blood taking and so on and so forth. Sometimes if you take blood for blood gas, for example, you would need around 0.5 mils of blood. Minimum is 0.2, 0.3, sometimes around average 0.5 mil just for blood gas. So, and then you take blood gas how frequent? Sometimes if babies are on HFOV, you will take blood gas every 1 to 2 hours. So can you imagine how much blood are you going to take? And we don't take just blood gas, we take ABC frequently, we take RP, LFT, coagulation. If a child has a thrombosis, for example, so if we need to take apa nama thrombotic screen, thrombophilia screening, you need to take 6 bottles. You need around 10 mils of blood from a baby. So can you imagine if the baby is just 1 kilo? If the baby is 1 kilo, total blood volume is just 80. Then you're gonna take 10 mils of blood. That's a lot lah. There's a lot. So remember those costs. Okay. Are you guys still okay to continue, or should we reschedule another session because it's already 10:30? You guys still alive, or I think is it okay for us to reschedule the other two lecture? Probably I think probably we did. Okay, you all okay nak continue? Narak ke?
I think you need to ask another, I mean, not the presenter.
I think it's better to reschedule.
That already, doctor.
Semua dah separa sedar. Okay lah, fine. Sorak betul. Okay, let's reschedule. I'm sorry to need to schedule this at night. It has been a very busy week. Actually, almost always busy weeks lah for us. Fine. If you have time during office hour, when you don't have lectures or lecture to you ada, because I think the last two we only need around 1 hour plus a bit. So even kalau pagi-pagi next week pun kita boleh buat dalam pukul 8 sampai pukul 9 pun boleh macam tu, or any other time pun boleh. Kalau tak malam pun okay, we can discuss back. Tapi malam tu lah, it's a bit difficult for me to start early. So 9 is just nice for me to start, because before that kena uruskan anak-anak semua. So sikit lah. Okay, alright. Let's end our session with tasbih kafarah.